Good morning, one and all. Today's topic for discussion will be diagnostic workup and surgical planning in orthognathic surgery. In the first session of orthognathic surgery, we were discussing about the basis of orthognathic surgery. We also had a glimpse of the diagnostic workup, and also we were discussing about the maxillary orthognathic surgical procedures. In today's class, we will be seeing about the diagnostic workup towards planning of orthognathic surgery. First, we need to understand the problem list. When we see the patient, we get the patient records, in the sense the chief complaint, how the patient looks. We also get the photographs, the dental models, all these things. And then to add on to the diagnosis, we have something called as the problem list. In the sense, you list down all the possible problem what the patient has. For example, it can be at the dental segment level or at the skeletal segment level. Beyond this, the patient can also have certain other problems, maybe difficulty in breathing, patient can have snoring, and various other problems the patient can have. So you list the problems what the patient is having. So when we talk about problems within the dental segment, it can be either of the malocclusion, crowded teeth, incisor angulation, which can be proclaimed, which can be retroclaimed, spacing between the teeth. So all these dental problems definitely needs orthodontic correction. And when we come up towards a skeletal segment problem, the patient can have a maxillary excess or a mandibular excess. Similarly, a maxillary deficiency or a mandibular deficiency. So these problems comes as a combination. For example, a patient with a crowded teeth can also have a maxillary excess or can also have a mandibular excess, or a patient with a maxillary excess can have a deficient mandible. So we need to understand that it comes with various combinations. So for each of these patients, you give a problem list so that you know that before starting with the treatment for these patients, you know that what are the problems that need to be assessed. When we are talking about the skeletal problem, for example, if the maxillary is excess, when we talk about maxillary excess, it can either grow vertically downwards or horizontally forwards. In the sense, it is based on the overjet. For example, between the mandibular incisors and the maxillary incisors, you need to have a overjet of 2 millimeters. For example, if it is in a case of a maxillary excess horizontally, the overjet will be more. When we're talking about overbite, in the sense the vertical overlap of the maxillary incisor over the mandibular incisor should be normally between 2 millimeters, but when it can be vertically more. So that is how you describe the problem list of the patient. So talking about the skeletal problem, okay, so vertical relationship. In a case with a vertical maxillary excess, who is a patient with vertical maxillary excess? To give a very good example, if any person who is having incisal show beyond 4 millimeters, we call it as a vertical maxillary excess. And these patients will have a characteristic gummy smile. When they smile, they have a lot of gingival show. So what happens to these vertical maxillary excess patients? The maxilla grows downward and backward. So the maxilla, you know that it is fixed to the cranial bone. So based on the growth of the maxilla, the mandible will also be positioned differently. In the sense, for a patient with vertical maxillary excess, okay, there will be rotation of the mandible in the clockwise direction. So when the mandible rotates in the clockwise, you can see in the first picture there will be a downward rotation of the mandible clockwise, resulting in increased lower anterior facial height. What happens in case with a vertical maxillary deficiency? In the sense, the maxilla has not grown downward, there is no incisal show, the maxilla is deficient. In these patients, maxilla is positioned upward and forward, rotation of the mandible, decreasing the lower anterior facial height. So these are the problems which can happen for the patient. And as I said, it can occur in combination. For example, a vertical maxillary excess patient can also have a deficient mandible. A vertically deficient maxilla can have a marked prognathic mandible. So it can happen in combination. So we need to understand, when do we treat the jaw, when do we treat the teeth, and which jaw need to be treated first and which jaw need to be corrected later. So for a skeletal problem, imagine if the patient is coming to the doctor at a much more earlier stage. The orthodontist can start with a functional orthodontic or orthopedic appliances. So functional orthopedic appliances guides the maxilla and the mandible to grow normally. It can either restrict the growth of the maxilla or the mandible. So there are various devices. If the patient has crossed beyond that stage into the adulthood, then definitely we need to treat these patients with orthognathic surgery in combination with orthodontic braces. Let's see how a vertical maxillary excess patient will be. So if you can see these radiograph, the graphical representation and also the clinical presentation, you can see clearly that is increased incisal show. As I was discussing, only 2 to 4 millimeter of incisal show should be present, but if you can see the clinical picture, you can see almost the entire incisor is seen, and when the patient laughs, there is increased show of the gingiva. If you can see the lateral ceph or lateral ceph image, you can see that how the maxilla has grown downward and backwards. Because of that, the mandible is rotated clockwise, resulting in increased lower anterior facial height of the patient. So that is how a typical vertical maxillary excess patient will be. If you can see about maxillary deficiency, you can see that there is anti-clockwise rotation of the mandible, resulting in reduction of the lower facial height. You can see that the upper lip is trapped behind the lower lip, because here the maxilla is deficient and the mandible has grown normally. So for these patients, if you can see, there is a clear-cut deficiency of the maxilla. Okay, so how do we assess all these things? So we need certain investigative tools. So when we see a patient, we need to describe whether the maxilla is deficient or whether the mandible is deficient, or the mandible has grown more and the maxilla is normal. So as I said before, it occurs in various combinations. So to come to a conclusion, whether the problem is in the maxilla, whether the problem is in the mandible, we need to do certain cephalometric analysis, and also importantly need to have a dental model. We'll see what are the investigations and the workup we need to do for the patient. We get the dental models. Why do we get the dental model on day 1 the patient walks in? Because as treatment progresses slowly, we need to understand how the teeth is moving, how the occlusion is changing, how the overbite, the overjet is changing. So all these you need to have a record. So you record the patient's dental arches, and then you get the basic OPG and lateral ceph. Then the ceph will be analyzed. We have many analyses. Most commonly used is Burstone analysis or Steiner's analysis. And then, as we discussed in the first class, we do something called as a model surgery splint fabrication, and then beyond all these steps, the final thing will be surgery. Okay, so throughout these investigation workup, what we gain particular knowledge about the patient, about the skeletal system, about the dental system, how the patient is going to cooperate throughout the entire course of treatment. Okay, so when we record the dental models, you can see in orthodontia department how they carefully get the dental models. Okay, and these models will be characteristically, when we position the maxilla and the mandible in all directions, it will maintain the occlusion. Hope you would have seen these models in orthodontia, how carefully they have worked upon these models, because it is of very much importance, because the treatment can take as long as 1.5 years to 2 years or even beyond. So we do not know how the patient was looking 2 years prior, how the patient's occlusion was, and how the occlusion has changed now. So that's why we maintain a dental record for these patients. Next, you get the OPG and the lateral ceph. In OPG, you can see whether there is an impacted tooth, whether there is an impacted canine, the spacing between the teeth, the nature, the quality of bone, the condyle, the joint space. All these will give certain relevant details for the patient. And the lateral ceph is very important, because periodically you will take x-rays. Lateral ceph is one such x-ray where if you can repeat it 100 times, you can exactly locate the patient, how the tooth has moved, how the bone has moved, how it has been modified, because it is all standardized x-rays. There is not much of errors due to magnification of the x-ray, or because of positional change in the patient. Okay, so an orthodontist gets an OPG and a lateral ceph. What has to be done after getting the lateral ceph? We call it as the cephalometric analysis. What is cephalometric analysis? If we can carefully see on this slide, okay, various points have been marked, at least 11 points. Very important. This diagram is very simple to even represent in your exams. You can practice this diagram and mark these points. For example, the cella. Okay, so that is where the pituitary gland is housed. Okay, so that is called as the cella. The nasion, the most anterior point of the frontonasal suture. Okay, then the porion, the posterior superior margin of the internal auditory meatus, that is your ear cavity. Okay, and then the orbital, the anterior inferior margin of the orbital cavity. Anterior nasal spine, you know about the anterior nasal spine. The tip of the anterior nasal spine is ANS. The posterior nasal spine, similarly, the tip of the posterior nasal spine. So you can draw this diagram and plot all these important points in the cephalometric radiograph. So what we do with the cephalometric radiograph, we place a tracing sheet, and then we mark all these points. We trace the face, we trace the maxilla, mandible, mark all these reference points, and then measure the angulation of the maxilla, mandible, the incisor angulation, the length of the mandible, the position, the FMA. So various angles can be measured. As I told you, the cephalometric analysis, there are various analysis techniques which are available. Most commonly, we will be using the Burstones and the Steiner's analysis. Let us go into the cephalometric analysis. Okay, something called as an SNA. Okay, if we can refer to the last slide, S denotes cella, N denotes nasion, and A denotes a point. A point is a point in the maxilla where it is at the anterior most deepest part of the maxilla. Okay, so that is point A. So why SNA is plotted? SNA gives the angulation of the maxilla to the cranial base. Similarly, for the mandible, we have something called as a SNB. It gives the angulation of the mandible or position of the mandible in relation to the cranial base. Okay, so using the cephalometric analysis or Steiner's analysis, what we can assess is we can assess the position of the maxilla to the cranial base, position of the mandible to the cranial base. We can also measure the incisor angulation, the mandibular plane, the occlusal plane. Okay, so all these angulations can be measured. So why these angulations are being measured? For example, if you can see the Steiner's analysis, so various measurements, almost 11 measurements have been done. You can see this SNA, angulation of the maxilla to the cranium, SNB, angulation of the mandible to the cranium. The angulation A and B is the angulation between the maxilla and the mandible. Okay, so this is how it has been graded. We can also, as I told you, we can also analyze the incisor angulation. We can analyze the nasolabial angle, the lower facial height, the middle facial height, the chin throat angle. Okay, so all these can be analyzed using the burstones or the Steiner's analysis. So working up on all these analyses, we come into a conclusion. So we have the dental record of the patient, we have the radiological assessment, that is a OPG and the lateral ceph, and with the lateral ceph we further do the analysis, which can be either burstone, hard tissue and soft tissue analysis, and Steiner's analysis. So we can assess the hard tissue, we can assess the soft tissue, we can assess the dental segment as well. So once all these things have been done, we'll have a problem list which is ready with us. So once the problem list is being created, so we need to address each of these problems.